Hi, my name is Dr. Min Kim. I'm a thoracic surgeon. This is a talk that I gave at the 7th Annual Exploring Frontiers in Management of Digestive and Liver Disorders at Houston Methodist Research Institute on August 19, 2022, titled Use of EndoFLIP During Foregut Surgery. These are my disclosures. The goal of the talk is to discuss EndoFLIP and how it can be used during hilar myotomy and hiatal hernia repair. EndoFLIP is high-resolution impedance planimetry that measures the luminal geometry and pressure during volume-controlled distension to provide mechanical properties of the esophageal wall and gastroesophageal junction. It is composed of a balloon catheter with sensors that are attached to the machine that provides information about minimal diameter, cross-sectional area, descent-split index, and pressure across the gastroesophageal junction. The EndoFLIP is very helpful in providing information about the restrictive area, especially during surgical treatment of a patient with achalasia. To illustrate this point with a case, we have a 76-year-old female with 3-year history of progressive dysphagia to solids and liquids. She also has heartburn symptoms and regurgitation symptoms. She reports that she has severe obstructive symptoms as well as moderate reflux symptoms. This is her past medical history, notable for factor V deficiency with history of DVT and hypertension. Patient's histogram showed a classic birth big appearance consistent with possible achalasia. The patient's manometry showed hypertensive peristalsis in 80% of her swallows with an IRP of 32.8. with a diagnosis of type 3 achalasia. The patient underwent robot-assisted hilar myotomy and door fundoplication with EndoFLIP to treat her symptomatic type 3 achalasia. After the ports were placed, we placed the EndoFLIP catheter across the GE junction. The initial minimal diameter across GE junction was 6.6 and dispensability index was 0.7. We then performed hilar myotomy. The minimal diameter increased to 10.5 as well as the descent index increased to 3.2. Finally, once we performed the door fundoplication, the minimal diameter decreased to 9.1 and descent index decreased to 2.2. At 1 month follow-up, the patient had resolution of dysphagia symptoms and improvement in her reflux symptoms. We evaluated those patients with achalasia undergoing hilar myotomy and door fundoplication to establish EndoFLIP values during the procedure that is associated with good outcome, and to determine if the values can help distinguish between achalasia and hiatal hernia. The median descent index prior to myotomy for patients with achalasia was 0.7 with 30 milliliters in the EndoFLIP balloon. After myotomy, the descent index went to 3.2, and after door fundoplication, it went to 2.2. This was associated with significant improvement in their Ecker score. Next, we evaluated if the initial values could help distinguish between those patients with achalasia and hiatal hernia. There was a significant difference in age, gender, and median IRP on manometry between the two groups. The EndoFLIP values showed that the patients with hiatal hernia had significantly higher minimal diameter, cross-sectional area, and descent index. We then performed ROC analysis with different cutoff points of descent index that helped to provide cutoff for different diagnoses. We discovered that patients with descent index of less than 0.8 have a 99% probability of having achalasia, while patients with descent index of 0.8 to 1.3 have 95% probability of having achalasia. Patients with descent index of greater than 2.3 have 99% probability of having hiatal hernia, and patients with descent index between 1.4 and 2.2 have a 94% probability of having hiatal hernia with 30 milliliters in the EndoFLIP balloon. We had 4 patients with manometric findings of concern for achalasia with elevated IRP despite not having dysphagia symptoms. When we measured their DI, all of them had DI greater than 2.3. We had 2 patients where achalasia was suspected, but the manometry could not be performed. Both patients had DI less than 0.8. EndoFLIP can provide objective data during heteromyotomy and door fundoplication, and it can distinguish patients with achalasia and hiatal hernia within a certain clinical framework. Occasionally, I have had patients without dysphagia with high Demeester score with an initial DI less than 1.3. Thus, a patient's symptoms should be used to guide therapy. I have yet to see a patient with achalasia diagnosis with DI greater than 1.3. When we think about anti-reflux procedure, we want the patient to have a perfect outcome, which in my mind is a resolution of reflux, no dysphagia, and durability. Is it possible to have objective data during the case that is related to patient's outcome? We evaluate the EndoFLIP data during the operation. In the literature, there are two different ways that EndoFLIP is used to generate data. One is continuous method, where the balloon is placed at the GE junction after hiatal hernia mobilization. 30 cc of volume is placed in the balloon, which is used to help close the crus and kept inflated during the creation of the fundoplication. For placement of links, the EndoFLIP is deflated and moved above the GE junction during sizing and placement of the links, and placed back at the GE junction for the final measurement. Other method is intermittent method, where the device is placed and removed at the GE junction after each portion of the operation, and inflated and measured after about 30 seconds. The first study that related measurements and outcome was a study published in 2013 that used intermittent strategy to gather data during Nissen fundoplication. They discovered that with 30 cc of the volume in the balloon, when DI was less than 0.5, they had to go back to the operating room and redo the operation because the patient could not eat. This kind of set the value where you should avoid during the operation or at the end of the operation. Next, Dehan et al. Published that DI after toupee fundoplication was higher compared to Nissen fundoplication, and also higher with 40 milliliters compared to 30 milliliters using intermittent strategy. In our early experience, when we used continuous strategy to measure the DI and use EndoFLIP as bougie and maintain DI greater than 0.5 by modifying the crus and fundoplication, there was no significant dysphagia 30 days from surgery. The DI of the toupee group was 1.3. Turner et al. Published that patients who had increased minimal diameter and cross-sectional area after fundoplication compared to pre-insufflation were found to have severe heartburn after Nissen at 6 months. The DI of severe heartburn group was 1.6, while no or mild heartburn group was 1.4. Su and al. Used intermittent strategy with bougie at times to create the fundoplication, showed that the final DI was 2.8 in the toupee group and 2.1 in the Nissen group, and found that the DI less than 2 was associated with more dysphagia and ballooning in 2 years. Not all of the patients returned the survey at 2-year point, and DI values were higher compared to the previous publication, possibly due to using a actual bougie during the fundoplication portion, which might have altered the final DI. Now, we looked at our series of patients where we use EndoFLIP routinely. Our method for EndoFLIP use was continuous strategy, where the EndoFLIP was used as a bougie to close the crus and to create the fundoplication. Now, for links, we used to help the closure of the crus, but we pulled it out during the sizing and placement and replaced it for the final measurement. We modify the crus closure and fundoplication to keep the final DI greater than 0.5. Here are the EndoFLIP views after mobilization of the hiatus, closure of the crus, and after placement of the links. In our study, we had 163 patients, most of the patients having type 3 hiatal hernia, 79 patients undergoing toupee fundoplication, and 68 patients undergoing links placement. When we evaluate the initial DI after placement for this group of patients, we found that the median DI with 30 milliliters of balloon was 3.2. For tooth fundoplication, median DI at the end of the case was 1.9 with the interquartile range from 1.5 to 2.5. This was associated with significant improvement in GERD with no significant dysphagia at 1 month follow-up. For a LYNX patient, the median DI was 1.6 with interquartile range from 1.1 to 1.8. This was associated with significant improvement in GERD without significant dysphagia. In conclusion, there is acceptable final DI depending on the technique used to obtain the data. DI less than 0.5 with 30 cc's in the balloon is associated with significant dysphagia. EndoFLIP is useful to help tailor barrier during anti-reflux operation. For future study, we're looking at the relationship between EndoFLIP values and long-term data and understanding the relationship between esophageal function and values at the barrier. Thank you very much.